Hi, I'm Michael Melman at the University of Queensland, Australia. Now we're going to talk about reproductive pathology. So for sex chromosome disorders of sexual development, one of the highest yield disorders on the USMLE Step 1 is Klinefelter syndrome, and the most important testable point is that the karyotype is 47XXY. Now normally we have 46 chromosomes, but the extra X chromosome with the male phenotype is characteristic of Klinefelter syndrome, so this is an extra bar body. So normally men who have an XY karyotype normally will not have a bar body. In Klinefelter syndrome, we move from the expected 0 bar bodies in a man to 1 bar body per cell. Okay? So the phenotype is male. Although we have 2 X chromosomes, it's not a female phenotypically. It's a male who appears unicoid, which is the characteristic description for a rather feminine appearance to the body shape. But it's a male phenotype and tends to be tall. So this is characteristic of Klinefelter syndrome. Now, one point I want to make is that on the USMLE, they will very rarely say bar body. So this term bar body will actually very rarely be mentioned on the Step 1, but what they might say instead is an extra electron dense aggregate in the nucleus of the cell. So what does that mean? Now, bear in mind that a bar body is heterochromatic, meaning it is not transcribed. It is silence. It is compact and electron dense. So this is not transcriptionally active. So it might be described as this electron dense aggregate in the nucleus of the cell. Whereas euchromatin, in contrast, is transcriptionally active and would not be electron dense. So the USMLE loves to characteristically give you an easy vignette of Klinefelter syndrome. They'll mention the tall male with a feminine appearance in terms of body shape or hair distribution. And then they'll turn it into a physiology question where they want to know the testosterone, the luteinizing hormone, the follicle stimulating hormone, and or the inhibin as up, down arrows, or remains the same. And you need to know that LH and FSH are both increased. So LH and FSH are both increased. That's mandatory. Okay, you need to know that for Step 1. That's extremely high yield. So LH and FSH are both increased, and testosterone is decreased, estrogen is increased. So, apart from just memorizing this, bear in mind that luteinizing hormone secreted by the anterior pituitary acts on the Leydig cells of the testes to secrete testosterone. And then testosterone will negatively feed back on the anterior pituitary as well as the hypothalamus, and there'll be a subsequent decrease in LH. So, in Klinefelter's, we lose this negative feedback. So in Klinefelter syndrome, testosterone, which is normally produced by the Leydig cells, is decreased, and inhibin, which is normally produced by the Sertoli cells, is decreased because both the Leydig cells and Sertoli cells are dysfunctional. Now, testosterone normally negatively feeds back on the hypothalamus and anterior pituitary to decrease luteinizing hormone secretion. Similarly, inhibin normally negatively feeds back on the anterior pituitary to decrease follicle stimulating hormone secretion. Because testosterone and inhibin are both decreased in Klinefelter syndrome, LH and FSH are both increased. Now, estrogen comes from the aromatization of androgens, and aromatase is produced by Sertoli cells. Now, although the Leydig cells and Sertoli cells are dysfunctional, which is why your testosterone and inhibin are both decreased respectively, the Leydig cells still have intrinsic aromatase production that is functional in Klinefelter syndrome patients. So we have decreased testosterone produced by the Leydig cells, but we still get a basal level of aromatase secretion. So this trace androgen, this trace testosterone that is produced by the Leydig cells is converted to estrogen. Okay, so we get increased estrogen, and we also get an increased estrogen to testosterone ratio. They love asking this as a physiology question with up and down arrows, where they will want you to know that FSH and LH are both increased, and estrogen is increased, testosterone is decreased, inhibin is decreased. Now let's discuss another important sex chromosome disorder, Turner syndrome. For Turner syndrome, you need to know that it's a disorder where females had the genotype 45X, so they're missing one of their X chromosomes. This means that they have no bar body because they only have X chromosome and no extra copy to inactivate. To remember, XO, or X, is the genotype for Turner syndrome. Some people like to use the mnemonic hugs and kisses, XO from Tina Turner. In terms of disease phenotype, patients with Turner syndrome are short females who have a shield-like chest and webbed neck secondary to poor lymphatic drainage. This neck mass is referred to as a cystic hygroma, and it is just a fluid-filled mass. It does not contain any cells. Now, patients with Turner syndrome, apart from having a short female phenotype, which in the USMLE vignette, they'll always mention a patient who's maybe 5'1", 4'11". Okay, they like to mention the short height associated with Turner's. They'll sometimes like to mention streak ovaries, which is synonymous with ovarian dysgenesis. Okay, so the ovaries fail to develop properly. And because the ovaries fail to develop properly, these patients will never menstruate. So it's the most common cause of primary amenorrhea, which means they've never menstruated prior. Secondary amenorrhea would mean they've menstruated before. Most common cause of secondary amenorrhea would be pregnancy, whereas primary amenorrhea could be an anatomical obstruction, such as an imperforate hymen, or just simply Turner syndrome. Now, Turner syndrome can be due to either meiotic or mitotic error. So, in order to elaborate on that, most of the time, Turner syndrome is going to occur due to failure of X chromosome migration during meiosis. Okay, so in terms of gametes, now, Turner syndrome can be due to either meiotic or mitotic error. It's most commonly due to meiotic error, where an ovum or spermatozoon that was supposed to have one X chromosome instead had 0. So when combined with the gamete of the opposite sex, we're missing an X chromosome, okay? So the net result is that all cells of the offspring, all cells of the daughter will have the karyotype XO, okay? All cells. Whereas, in contrast, if there's a post-fertilization mitotic error, where during cell division there is improper segregation of X chromosomes to daughter cells, then there will be a resultant mosaicism where a fraction of the daughter cells will have the XO karyotype and the other fraction will have a normal XX karyotype. So the bottom line is that if they ever mention a mosaic Turner syndrome patient, you need to know the answer is post-fertilization mitotic error if they ask you the mechanism for the disease. Here's another patient with Turner syndrome, and you can see the webbed neck. Because of the 45 XO karyotype, patients only have one copy of the SHOX gene instead of 2. You don't need to know SHOX gene for step 1, but this at least makes you aware that this is why patients with Turner syndrome are so short, is because the SHOX gene is responsible for long bone growth. And just remember that in a vignette they will mention the short height. Another clue to the Turner syndrome diagnosis is if they mention a preductal coarctation of the aorta. Most coarctations occur downstream with respect to the ductus arteriosus and are therefore postductal, but Turner syndrome patients get them upstream. Make sure you remember this because it is a frequently tested feature of the disease on step 1. Remember then, from cardiology, what would you expect to see on physical exam, cyanosis or not? You would expect to see cyanosis because there is low pressure distal to the coarctation, which allows shunting of deoxygenated blood through the ductus arteriosus. You would not observe this with a postductal coarctation because the pressure differential doesn't develop until after the ductus arteriosus inserts. Some things to keep in mind are that these patients have non-functional streak gonads and therefore have decreased estrogen levels and increased LH and FSH, which results in primary amenorrhea. They are also likely to have diabetes and be hypothyroid. Another thing you need to be aware of regarding Turner syndrome is that these patients have increased risk of horseshoe kidney as well as increased risk of Wilms tumor, and their streak ovaries also confer an increased risk of ovarian cancer. Now, true hermaphroditism is fairly rare, and it's characterized by the presence of both ovarian and testicular tissue, also known as ovotestis, and the karyotype can be variable for true hermaphrodites. Double Y males on USMLE Step 1 will characteristically be very tall with severe acne, and the USMLE also likes to mention the association with prison inmates and criminality. And criminality is a component of antisocial personality disorder. The 47XYY karyotype is characteristic of double Y males. And don't confuse this with Klinefelter syndrome, which is 47XXY. Now, this is a very high-yield chart in first aid discussing testosterone and luteinizing hormone with regard to various diagnoses. The USMLE will frequently assess this material as physiology questions. Now recall that testosterone normally exerts negative feedback on the hypothalamus and anterior pituitary to decrease luteinizing hormone secretion. Now if the androgen receptor is defective, the hypothalamus and anterior pituitary perceive it as if testosterone isn't present. So luteinizing hormone increases to compensate for what is perceived as this lack of testosterone. Okay, so luteinizing hormone is up. Now luteinizing hormone acts on the Leydig cells in the testes. There's nothing wrong with the luteinizing hormone receptor, so this increase in luteinizing hormone leads to increased activation of the Leydig cells to produce testosterone. So we have increased luteinizing hormone and increased testosterone in the presence of a defective androgen receptor. Now if we have a testosterone secreting tumor, testosterone is obviously increased, okay? And this will negatively feed back on the anterior pituitary hypothalamus, leading to decreased LH secretion. Now, the decreased LH secretion you'd think would normally lead to decreased testosterone production from the Leydig cells, which is true, but because we have a testosterone secreting tumor, this decreased LH is not going to lead to decreased production of testosterone from the Leydig cells. The testosterone is going to be increased regardless. With exogenous steroids, testosterone is increased because we're supplying the steroids, and negative feedback on the hypothalamus anterior pituitary, LH is decreased. However, in contrast to the testosterone secreting tumor, the decrease in LH will lead to atrophy of the Leydig cells and subsequent decreased production of endogenous testosterone. So, in both of these cases, testosterone is up, LH is down. But with the testosterone secreting tumor, it's an increase in endogenous testosterone. With the exogenous steroids, we have an increase in testosterone that's exogenous with a decrease in endogenous testosterone production. Now, primary hypogonadism means that the hypogonadism is located at the organ itself. So the problem is with the testes themselves. If we were to say secondary hypogonadism, we'd be referring to something upstream, such as the anterior pituitary, which can't secrete LH or FSH. Okay? Or tertiary hypogonadism would be a problem with the hypothalamus. Okay? But primary hypogonadism means that testosterone is decreased because the problem lies within the testes themselves. So it could be decreased Leydig cell production of testosterone. Okay? And without the production of testosterone from the Leydig cells, we lose that negative feedback on the hypothalamus and anterior pituitary, and the secretion of LH increases. Now, although LH increases from the anterior pituitary and acts on the Leydig cells of the testes, because the Leydig cells of the testes are not producing testosterone the way that they should, testosterone is still decreased. Now, with hypogonadotropic hypogonadism, this refers to either tertiary hypogonadism, which is decreased GnRH secretion from the hypothalamus, or secondary hypogonadism, which is decreased luteinizing hormone from the anterior pituitary. The net result is that luteinizing hormone is decreased in both. So decreased luteinizing hormone means decreased activation of the Leydig cells in the testes, decreased testosterone production from those Leydig cells, and then you'd expect, because there's decreased testosterone, that there'd be decreased negative feedback on the hypothalamus and anterior pituitary, which would result in increased luteinizing hormone secretion. But because luteinizing hormone is decreased in the event of decreased testosterone, you can infer that the problem is at the level of the hypothalamus or anterior pituitary, and not at the testes themselves. So the main difference between primary hypogonadism and hypogonadotropic hypogonadism is that in primary, luteinizing hormone is up, and in secondary and tertiary hypogonadism, luteinizing hormone is down. Now, two pathologies you need to know for step 1 are female versus male pseudohermaphroditism. So unlike true hermaphroditism, where both ovarian and testicular tissue are present, for pseudohermaphroditism, there's only one type of tissue present. Now, for female pseudohermaphroditism, the karyotype is female. So we have 46XX, but with a male external phenotype. And similarly, for male pseudohermaphroditism, there's a male karyotype, so 46XY, but with female external phenotype. Now, for female pseudohermaphrodites, they have ovaries, but their external genitalia are ambiguous or more male-like, and one way this happens is that during fetal development, they may have had some exposure to testosterone, either exogenously or endogenously, such as from congenital adrenal hyperplasia. Male pseudohermaphrodites, they have testes, but the external genitalia are female or ambiguous. Again, the big example is androgen insensitivity syndrome or testicular feminization. The way to remember male versus female pseudohermaphroditism is that the patient's actual genotype precedes the word pseudohermaphrodite. So a male pseudohermaphrodite is actually a male, but will look female. And a female pseudohermaphrodite will actually be a female, but will look male. Now for the flash quiz, if the androgen receptor is dysfunctional, would the luteinizing hormone and testosterone levels be up, down, or would they remain the same? That's right, they would both increase, because without a functional androgen receptor, the anterior pituitary and hypothalamus perceive it as if the testosterone isn't there, so they increase luteinizing hormone to compensate, and then luteinizing hormone acts appropriately on the Leydig cells of the testes to increase testosterone. So we have loss of the negative feedback by testosterone on the hypothalamus and anterior pituitary, leading to increased luteinizing hormone, increased testosterone production.